I would like to thank Srinath sir, Dr. Radhika, Sriram and Karthik for this invite. My topic is on Orocutaneous Fistula. We all know what a fistula is. It is nothing but a connection between two epithelial surfaces, and it is broadly classified as internal and external fistula. But what makes fistula very characteristic is mainly dependent on the epithelial lining surfaces that it joins. Like if you take, for example, a pancreatic or a biliary or an enteric fistula is going to have a higher rate of mortality than what we normally see. Oral cancer forms the major bulk of our clinical practice, and surgery forms the mainstay of treatment in these patients. Orocutaneous fistula, being an classical external fistula, is most commonly encountered surgical complication. The incidence of it ranges between 8 to 20%, and literature also suggests an high incidence rate of 65% uh, when the papers have combined both pharyngocutaneous and orocutaneous fistula together. When the oral mucosa is intact, our salivary secretion acts as a guardian to our digestive tract. All the But when there is a breach in the mucosa and the wound gets contaminated by saliva, various detrimental effects like infection, delayed wound healing, tissue lysis, finally resulting in orocutaneous fistulas, and which in turn further complicates when the dreaded complication like carotid blowout is seen or sepsis. Not just it doesn't just have local implications but also has various other implications. Does it affect survival? Yes, definitely, mainly because it delays the adjuvant treatment that we give to the patient. We all are aware that we have to start the adjuvant treatment preferably within the 6 weeks of surgery, but that gets most often delayed when the patient has orocutaneous fistula. When we look at literature, what causes perioperative mortality in oral cancer surgeries, the data again suggests and indicates towards orocutaneous fistulas and its consequences like postoperative infections and its further complications like rupture of carotid artery. So, how when we are tackling with orocutaneous fistula and when we look at the factors that cause orocutaneous fistula, we can broadly classify it as tumor factors, patient factors, and surgeon factors. This is probably just a classification for us to remember these factors and uh, use in a clinical practice. But when you look at these factors deeply, the tumor factors are usually non-modifiable. There is nothing we can do about these factors or change these factors, but just adapt around these factors. And the patient and the surgeon factors are most often modifiable, and there is always something we can do about it. And non-modifiable factors also act as predictors, so we can preoperatively a lot of times predict who are going to end up in a dreaded surgical complication like orocutaneous fistula. An advanced clinical stage, for example, is this patient where is a T4 cancer of the buccal mucosa. You can see that there is a large local disease with a large defect in the skin. The patient also has another node which is involving the skin. So this is a large defect with multiple components involved, and each defect is at a different level. And these are the kind of patients where our reconstruction also complicates, and hence the higher rate of surgical complications in these patients. It is further compounded by poor nutrition and malnourishment, which impedes wound healing. Literature shows, sorry for the spelling mistake, but floor of mouth and buccal mucosal sites are most commonly, tumors of these subsites are most commonly affected with orocutaneous fistula. Why does that happen? In advanced floor of mouth and also even in large glossectomies, there's a large volume defect that is created between the mandible and the hyoid, which is almost approximately 5 into 3 into 3 centimeters. And this is a large dead space that has to be accounted during reconstruction. Otherwise, this dead space is going to have blood accumulated or saliva or serous fluid accumulated in it, which results in surgical site infection and orocutaneous fistula. Even in an early floor of mouth tumor, sometimes a small, minute, even a 1 millimeter breach in the mylohyoid muscle can lead to orocutaneous fistula. Like, I think I forgot to add that this was actually a floor of mouth patient who had, we used a infrahair flap. The patient had orocutaneous fistula mainly because of partial flap loss, and there was a large defect connecting the oral cavity and the whole of the neck. The next subset that is commonly associated with orocutaneous fistula is buccal mucosa. But why does that happen is because there are more spaces to fill in buccal mucosal resections, and also there are more components for us to reconstruct, which further complicates our reconstruction ladder. Prior radiotherapy, we all know, impedes wound healing by causing extracellular matrix alterations, fibroblast dysfunction, there is cellular depletion, which finally results in fibrosis and makes local wound healing very difficult. There is also poor donor vessel quality in these patients. There is a higher chance of wound breakdown in these patients, and also most often result in multiple re-exploration. An example would be this patient who was a case of CA lip who underwent brachytherapy, failed brachytherapy, and we had to do a radial forearm. This patient underwent 4 re-explorations just for venous congestion, and I think it's not very evident in the photo, but he developed a large orocutaneous fistula posteriorly, luckily which healed by conservative management. Then one of the preventive factors that result in orocutaneous fistula is nutrition. When we look at nutrition, which it is quite prevalent in head and neck cancer patients, and preoperative carbohydrate loading usually benefits most of the patient. When we look at, I'm sorry for the image quality here, it's taken from the book directly. When we look at malnutrition, it is broadly classified as uncomplicated and complicated. So an uncomplicated malnutrition is what we see preoperatively, where it is mainly because of mechanical obstruction for the patient. So patient does not have any other micronutrient deficiencies, or the cytokine mediated malnutrition effects are usually not seen in these uncomplicated malnutrition. And in these patients, when we give a high calorie and a high protein diet, we will be able to maintain the lean mass, muscle mass for the patient. A complicated malnutrition is what we commonly see postoperatively or associated with orocutaneous fistulas, which is usually cytokine mediated, which results in decrease in the lean mass. There are various multiple micronutrient deficiencies which affect wound healing. So what actually happens when we do a surgery in these patients is that as soon as we perform the surgery, the patient enters into an acute critical phase which usually lasts for the first 5 days. So what happens in the first 5 days is the body adjusts and tries to rebuild protein and tries to rebuild the body by increasing protein synthesis. There is higher nitrogen retention also during this phase. This phase is when the patient needs maximum protein supplementation than caloric supplementation. And if there is a chronic insult, or if there is an ongoing insult like orocutaneous fistula or an infection, the patient enters into a prolonged acute critical illness, which is usually beyond 5 days. So what happens is that in the patient or the patient's body mechanisms become very resistant to most of the treatment modalities that we give the patient. So this happens at the metabolic cost of adaptation, of prolonged adaptation, which later on results in organ dysfunction. In this phase, the patient is most prone for dehydration, most prone for electrolyte imbalances, if not corrected, and can lead to mortality. So this window of 5 to 10 days is when the maximum post-operative mortality can occur. If the insult continues and the patient survives, then they enter into chronic critical illness. This is what we actually normally see. Most of the patients do come out of the catabolic stage of the prolonged acute critical illness, and patient again re-enters into the anabolic metabolism, and the patient starts to heal. And this is probably one of the best window that we get to correct anything surgically. Comorbidities like diabetes mellitus and also patient's psychological status does affect wound healing. This is mainly because in acute stress there is a increase in the glucocorticoid steroid hormones. There is altered immune response, and most of these patients also have a uh, uh, are more habitual smokers or increased alcohol intake, and also have poor nutrition and poor compliance to most of our surgical instructions. In diabetes mellitus also we have a similar situation where hyperglycemia induced oxidative stress is very high and which further impairs wound healing. Prevention, that is the surgical factors. The most commonest reason why we end up with orocutaneous fistula is probably a poor surgical planning. And surgical planning should start preoperatively, should be continued on the operating table and also in the post-operative period. The ERAS protocol, which is published for perioperative care in major head and neck cancer, has tabulated well most of the recommendations that need to be checked and ticked during the pre and per operative period. So we'll have to, as already said, the nutritional status has to be taken care of. Patient's oral hygiene has to be taken care of. MRSA decolonization and antibiotic prophylaxis has to be administered because most all oral cavity cases are clean contaminated wounds. Intraoperative cardiac output monitoring is also essential to have an uneven.
Samskruthi.
Antibiotic prophylaxis is essential to prevent surgical site infection, which is one of the first event in a orocutaneous fistula. The most commonly used antibiotics are cefazolin along with metronidazole, ampicillin, or ampicillin with clavulanic acid. The duration of prophylaxis usually is on day 1 or 1 hour before the induction. With high advanced stage diseases will result in high volume defects, which will most often require double flaps, either 2 free flaps or a free flap and a regional flap, or sometimes even a 2 local regional flap might be required. It is extremely important for us to decide how the defect is going to be. Like the photo that I showed you, you'll have to divide the components of your resection as the cutaneous defect, mucosal defect, soft tissue defect, and bone defect, and then plan appropriate reconstruction to compensate for the components that you have resected. A proper flap design is extremely crucial. We cannot have a flap that is too small or a flap that is going to pull on the surgical defect and lead to wound breakdown. Even though we plan everything, a lot of times there could be an erroneous execution of the reconstructive plan. And this happens when we don't give a watertight closure, especially in areas where we know is prone for salivary accumulation. We'll have to check for reliability of tissue that we stuff in the dead space. I've already previously told that you have to cover the dead space, especially in buccal mucosa defects. You'll have to fill ITF with vascularized tissue. If you put in a tissue that is devascularized or unhealthy or is vascularly compromised, then we will in fact be creating a cavity with infected material. Meticulous suturing techniques, especially to minimize tear along the suture line, is essential. I'm sorry, this should be an overlying skin. The gaps between the reconstruction plates and the overlying skin has to have an intervening bridge of soft tissue components to prevent wound breakdown and orocutaneous fistula. These are some of the examples where my poor surgical planning resulted in complication. This was a bipedal radial forum which I used to cover a large buccal mucosa defects, and the resultant was this patient had a non-healing orocutaneous fistula because the flap was too small for that defect, and probably if I think back, an ALT would have been a better fit for this patient. Similarly, in a patient where I planned a PMMC where I thought might not have an exterior skin defect, I ended up taking the cheek skin as the additional three-dimensional margin, and being a muscular patient, I had to take a large skin defect which was overlaying the rectus abdominis muscle, and in the post-operative period, ended up losing the exterior flap that was from the overlaying the rectus muscle. Or in this case, where the overlying native skin was lost mainly because of poor planning. I didn't anticipate that I would have to take the third dimension from the skin. Being an adenocystic carcinoma, I compromised and shaved and gave additional margin along the epidermis, and finally in the post-operative period, the native skin gave way, exposing the fibula and the plate underneath. As I told, good suturing technique is extremely important. The point of contact between your needle and the mucosa or the skin is extremely important. It should either be 90° or it should be 60°. If this angle is more acute, you're going to tear the mucosa, especially posterior mucosa very close to the tonsil or soft palate. You might not get a good bite, and at these places you have to make sure that angulation is straight so that you can get a good chunk of your mucosa as a bite into your sutures. Remember, oral cavity is extremely unique because even though it is a saliva filled environment, still most of the sutures and most of the wound heal. But still, the saliva has its own implications, and it does affect the suture material that we use routinely. This is a systematic analysis where they have looked at how saliva reacts to the various suture materials when used intraorally. They have shown that although silk was very biocompatible, was extremely had a very good handling, was most often had a lot of high amounts of bacterial and fungal accumulation. While PGA, although there was a lot of knot unwinding that they saw in the series, they saw that there was least or minimal amount of bacterial contamination, fungal contamination on the suture. Knot security is again extremely important. Either square your knots, use surgeon knots, or square your knots and make sure that the knot is placed well, and there are no loose spaces within your knot. It is extremely important that you use either 3 to 4 throws, especially for vicryls, and you have to apply at least 50% of pressure to get a good knot before it breaks down. Maybe this is something that Shana sir used to tell me and I never understood in my beginning years. And as you continue to suture and do insets, you will realize when the suture is going to break down and when you need to stop when you're tightening your knots. So, is overzealous tying of the knot okay? Definitely no. We have to make sure that when we tighten the knot, there is no adjoining mucosal or dermal blanching that we see. If you do that, you know that suture is going to give way later on in your post-operative period. Make sure the edges of your mucosa and skin is averted, and make sure that your sutures are not too close. It is extremely important for you to have a good access for a good inset to prevent orocutaneous fistula. Make sure that you envelop your flap at the bone edges, be it superior or inferior, because these are the two main anchoring stitch. Although this image was taken from JOMS, where an envelope flap is designed to go around the teeth, the same principle holds good when we are inserting the flap even in oral resection defects. In cases where you know you're going to end up with a fistula, it is probably best to create a planned fistula. So this was a case of huge ALT. We were not able to achieve a good hemostasis. We were running out of time. And once the inset was closed, we could not go back and find where the bleeding was. So instead of closing the whole cavity and creating a cavity filled with blood to cause infection and wound breakdown, what we created was a posteriorly placed controlled fistula, which we'll drain and close later over the next 5 days. Your duration of surgery also has implications. With higher the surgery, the higher the risk of infection, and hence the higher the rate of orocutaneous fistula. So even after you do all this, you might still end up with orocutaneous fistula. Unlike pharyngocutaneous fistula, there is very less literature recommendations proposed to manage orocutaneous fistula. This is a recent publication by Shivkumar sir, who have graded orocutaneous fistula into 3. This helps us and guides us when do we reconstruct and when we don't, and what is the prognosis of these orocutaneous fistula. So grade 1 is usually nothing but where you see early signs of infection, which looks like a very early surgical site infection, where you might have either pus discharge or sometimes rarely a frank salivary leak can be seen postoperatively. You can see there will be some amount of local erythema, swelling, local rise of temperature, fever. Raised WBC counts, raised CRP are also indicative of surgical site infection and a potential orocutaneous fistula. Literature does talk about serum amylase in the drain fluid. I never use it. I have not heard of anybody using it, but can be used to indicate an early fistula. So when we talk about conservative management, best is to drain the area, get a culture sensitivity, start the antibiotics based on your culture sensitivity report. And remember, infection and fistula almost always coexist, and it always runs in a vicious cycle. So when you're doing your conservative management, extensive wound care, debridement, infection treatment, and optimization of the hemodynamics is extremely important. All the literature does suggest modern wound dressings, but these are extremely difficult to use in orocutaneous fistula because you have tongue on the inner side, which will block using these products. Negative pressure wound therapy is extensively used in pharyngocutaneous fistula. There are reports of it being used in orocutaneous fistula, but again, it's difficult to maintain a negative pressure in orocutaneous fistula. Hyperbaric oxygen therapy, I think Dr. Ratan will cover in post-radiation wounds and osteoradionecrosis, and I'm not going to talk about it. So these are the various dressing options that we have, and probably the best would be just a sterile gauze piece, which is very easily available. And because the wound is extremely exudative and high output, it is advisable to do frequent changes and frequent dressings. You can start the patient on anticholinergics like glycopyrrolate to reduce the salivary production and bring down the salivary output from the fistula. Although botulinum toxin and octreotide is used, but they're commonly used when you see salivary fistulas associated with parotid gland than a frank orocutaneous fistula. Remember, when you're doing a dressing, all you have to do is convert the defect, which is 3-dimensional, into two-dimensional. We all are aware that wound healing causes a concentric contraction during the wound healing phase. So during this time, what you need to do is cover up the areas that have potential dead spaces. You start moving the local available healthy tissue to close as many defects as possible. And this patient actually had their neck wound also open, so she had a pocket here anteriorly in the submental region. She had a pocket here posteriorly, which by even pressure we closed down these pockets, closed the neck wound, and converted this partial PMMC loss into a 2-dimensional defect, which we grafted in our minor OP. So conservative management works very well, especially when there is no present in the infected wound. So what do you do when your orocutaneous fistula is not healing? So you have to take the patient up and consider for a second flap. Whether you do a free flap or a regional flap, that is based on the expertise that is available to you. Remember, if you are choosing to do a free flap after a failed free flap, make sure you have checked all the boxes, make sure you have corrected the reason that the free flap failed in the first setting. Various regional flap options are available after a failed free flap, like PMMC, deltopectoral flap, supraclavicular flap, or an LD flap or a trapezius flap. In rare instances, we might not be able to salvage these patients. Does it happen? Yes, it happens. This was actually a case who was retroviral positive. This patient developed miliary tuberculosis and she had a partial loss of the PMMCs, and we could not take her up for the second surgery. So what we did was give her an interim prosthesis just to make her look more acceptable when she goes in for her anti-tubercular therapy. Although rarely spoken in literature, there are few case reports where they have used interim prosthesis in these salvage settings. So to conclude, orocutaneous fistulas can lead to devastating complications, and the only way to avoid them is by optimizing your surgical plan, technique and execute your plan on table and follow the patients up well in the post-operative period. Thank you.
Thank you very much, Dr. Samskruthi, for this very comprehensive presentation on this important topic on orocutaneous fistula. You have taken us through the various aspects of technique, talking on tension-free closure and watertight closure, which is very important, and nutrition, probably one of the most important thing which causes this one. When we put in tissues from outside, generally the skin and mucosa, the healing itself takes a long time. What's your protocol on starting oral feeding? I mean, normally we put them on Rayleigh tube feeding or peg feeding. How much time do you normally give to prevent orocutaneous fistula?
So enteral feed we will start immediately post-op, and intraoral feed, if 5 days is when we check. Especially in free flaps, it is usually 5 days, and when we see flap changes is when we delay. Otherwise 5 to 7 days is when we inspect intraorally and start intraoral feeds.
And what's the antibiotic protocol which you follow? Any specific?
Kidwai, amoxicillin, clavulanic acid along with metronidazole.
Anaerobic cover is very important. Metronidazole is something which we need to use a lot more. Any floor is open for discussion. Any questions for Dr. Samskruthi?
Thank you, ma'am, for the enlightening term. Just had one quick question. In pre-operative period, when the patient comes, is there any protocol which you follow for nutrition, improving the status, like from date of registration or date of diagnosis? You start RT feed, and especially the sector of population which is non-affording, which like
and also patients who have trismus, who are already nutritionally poor,
compromised.
and you're planning a free flap on them. Anything?
No, in patients whom we think are nutritionally in Kidwai, obviously they're not very affordable. We do put in a Rayleigh tube, start them directly on enteral feeds, and most often we advise them to use ghee, oil, just to increase their calorie intake. In pre-operative period is when you need higher calorie than protein, because as I told you, it's an uncomplicated malnutrition that exists. So usually in high calorie intake is what we start. In trismus, if I think about it, I think most of our trismus patients actually most often have submucosal fibrosis. They're adjusted to trismus. So I don't very rarely see a trismus patient. Most often are in the younger age group.
But they're
not
nutritionally deprived also.
Most of them tumor-related trismus, yes. But in patients who have oral submucosal fibrosis and trismus are usually younger, and they would have adapted to take adequate intake.
Thank you.
I think the point of patients with trismus having, you don't see them being that much nutritionally, deprived compared to hypopharyngeal malignancy where there is dysphagia. Oral cancer patients are not that badly nutritionally depleted. But yes, nevertheless, you need to check the preoperative protein, total protein, albumin and hemoglobin. If that can be corrected, that should be corrected, and the comorbidities, that needs to be taken care to ensure the post-operative healing takes place properly.
But we do have funding in Kidwai for serum albumin supplementation, so that we do use rarely. We, as Sir said, oral cavity patients very rarely, more so in post-recurrent malignancies when we see their very young, thin, lean, their body mass index is very low. So these are the patients most often who require more nutritional supplement than oral cancer patients.
Sir, I have one more question, and ma'am to you also. So to look for the nutritional status now, the European and Americans, so what they are doing is like in the CT scan, what they are doing, they're looking at the vertebral muscle.
Yeah, they're looking at the sarcopenia.
Sarcopenia. So do we have anything in your institute?
We have started a feasibility study to look into sarcopenia in these patients, but we are running. It's just at feasibility state because our CT scan stops at lung, so it is very difficult for us to get CT scan of the abdomen also done. But serum albumin is what we routinely check. We routinely see albumin, hemoglobin for sure.
Yes.
Of course, there's a lot of literature emerging on sarcopenia, but we have not started looking at it. But that's been mentioned as one of the factors for various post-operative complications. But that needs an additional investigation many a times. But what you can actually act upon is if you just many times we do the pre-operative hematological investigations like hemoglobin and albumin, we don't look at it. We need to look at it and correct it if it needs correction. I think that that will go a long way in helping the wound healing.
Right. Actually, if surgeon misses, the anesthetist picks it up. So they'll never go through if the hemoglobin is low. I'm sure Akshay is nodding. He knows how Kidwai anesthetists are. Hemoglobin low, albumin low. They will not even accept the case. So we have to correct it. So we are almost sometimes forced to correct it.
Yes, these are tricky situations. The nutritional experts always say that the parenteral nutrition or enteral hyperalimentation, whatever you do in malignancies, should be restricted to about 5 to 6 days. You can't prolong that because subsequent to it, the tumor also starts growing because you are feeding it. So your efforts are actually limited to controlling oral infection, preparing the patient very quickly, and a short course of probably parenteral nutrition and some albumin therapy, and then take the patient for surgery, because you can't delay surgery also for till you keep on building the patient's nutrition. So it's a catch-22 situation. I think each individual case we have to take it, and our effort should be to build the patient's general health as quickly as possible.
Sir, I would like to invite you to felicitate ma'am for the same.
Sir, yes.